It has been an absolutely fabulous 3 days, and I'm pleased to say that we have saved the best for last. So those of you that have stayed till the very end are in for a real treat. It is my distinct privilege today to both welcome and introduce Stanley Zlotkin, who is a professor of pediatrics, public health sciences, and nutritional sciences at the University of Toronto. He was appointed to the position of VP Medical and Academic Affairs in July 2010. Dr. Zlotkin and his program, the Sprinkles Global Health Initiative, has focused on research and advocacy to control micronutrient malnutrition in children. He is the past chair of the Canadian Pediatric Society Nutrition Committee and is a frequent consultant to governments and United Nations agencies on issues related to pediatric nutrition. He was awarded the H.J. Heinz Humanitarian Award in 2001 for his international contribution to the health of children globally, and he was recently awarded the Order of Canada, the highest civilian honor in Canada, for contributions to improving the lives of children globally. Would you please join me in welcoming Dr. Stanley Zlotkin, whose talk will be titled The Use of Science, Innovation, and Partnerships to Begin to Control Micronutrient Deficiencies. Welcome, Dr.
Thank you, Dr. Christakis. And ladies and gentlemen, I'd like to thank the organizing committee for allowing me the opportunity to come and speak to you this afternoon. I guess as the final speaker, I have two challenges. One is the fact that I'm the final speaker, and I'm impressed that there are so many people in the audience. Thank you for staying. The other challenge is that I think it's always slightly difficult to give a talk to a mixed audience. And I understand that some of the audience were focusing on issues around child and youth mental health this week, whereas others are pediatricians. And I guess what I would say is that I think my talk, if it's taken in the right context, will be appropriate for everyone in the audience. And I think during my talk, I'd like you to think how you can apply the words, the knowledge, and the general principles that I'm about to talk about. The fact that I'm giving the general principles around a nutrition topic is really not important. What is more important, again, are the general principles around the use of science, innovation, and partnerships, in this case to control micronutrient deficiencies. But what I'm really talking about is beyond knowledge translation, and I'll tell you what that means in a moment. It is actually true that we know what to do to improve nutrition and child survival. And this was well enunciated and written about in the Lancet series on child survival now nearly 8 years ago in 2003. But I think it's fair to say that although we know what to do to improve nutrition and child survival, we still do not know how to actually do it. And I'd like to read you a quote from Dr. Margaret Chan, who's the Director General of the World Health Organization, who said, "The power of our interventions and all the evidence behind them is not matched by the power of our delivery systems to make these interventions available broadly and reliably to large numbers of people." And that's really what I'm going to talk to you about over the next 40 minutes. So this lecture is really going to be talking about scaling up interventions that work. And it's the process of taking an intervention full circle from the idea stage to the research stage to its implementation and finally to scaling it up. And in my talk, I'm going to be talking about public health. But again, in the context of your individual lives, think about this circle of ideas to research to implementation and to scaling up. So here's the definition I'd like to use of the concept of scaling. So scaling is the process of expanding the scale of activities with the ultimate objective of increasing the number of people receiving the intervention and, very importantly, increasing the impact of whatever intervention we're talking about. The emphasis is on interventions that have been tested in a particular country and then often scaled up in the same country, although that's not necessarily always true. So here's a question for you. Is this true, or is this a popular myth? And here's the question. Good ideas spread of their own accord. They may be so groundbreaking, involve such pioneering technology, and meet such pressing needs that they proliferate seamlessly from person to person, from organization to organization, from country to country, primarily because they're good and they make sense. So the question is this true or is this a myth? So someone said, what did you say? Well, the answer is that it's a myth. Most good ideas do not spread with such ease. They require the backing and the energies of committed individuals and organizations to design and carry out strategies for their expansion that are carefully tailored to the realities of their specific settings. It's too bad it's not true, but I don't think it is. So, on this slide are what I would define as the characteristics of an intervention that facilitate its successful scaling. So here they are, and these are really important, and I'm going to come back to these later. So the first characteristic is that it has to be credible. It has to be based on sound evidence, and I'm sure everyone would agree with that. It has to be observable to ensure that the potential user can see the results. So you have to be able to observe the results. It has to be relevant for addressing persistent problems in the area in which you're working. It has to have a relative advantage over existing practices. It can't be the same as something else. It really has to have a relative advantage. It has to be easy to use and understand. The demand for the intervention either has to be already present or it's up to someone to create the demand so that someone would know that they need this particular intervention. And finally, and importantly, it has to be compatible with the potential user's established values, norms, and facilities. So I'm going to come back to these, but I would say that these are the characteristics that define a successful scaling program. So here's the other important slide I'd like you to show you, and this is the big picture of taking research to scale. So on your left-hand side, we have a number of research projects. And if you put these research projects together and you do some type of a systematic review, let's call it a meta-analysis, one can finally say that you have, in single quotations, a proven intervention. The next step with your proven intervention is to translate this knowledge or transfer this knowledge using the field of knowledge translation. And once you have this knowledge translation, it is then appropriate to do local projects with the intervention. After you've done the local projects, there is a new science which people are calling implementation science. And with implementation science and the presence of a champion for the local intervention or a sponsor for the intervention, you can expand the local projects to subnational coverage. And then, again, having a champion or a sponsor, it is possible to go from subnational coverage through franchises, through some kind of replication, or through some type of expansion by taking it to scale to national coverage, which means you've got it in the entire country. So this is the big picture of taking research to scale. And I'm going to give you an example of how to do this. So that's the big picture, and now I'm going to talk as a nutritionist to talk about vitamin and mineral deficiencies. Vitamin and mineral deficiencies are often called hidden hunger because unlike the hunger, or the real feelings we have in our abdominal stomachs when we're actually hungry, people can't usually feel vitamin and mineral deficiencies. Thus, the local vernacular that they're given is something called hidden hunger. In terms of vitamin and mineral deficiencies, it's estimated that 750 million children are affected, and in fact, they may contribute either directly or indirectly to 2 million child deaths annually. They are certainly a leading cause of arrested development in children between 6 and 24 months of age. They affect the GDP of countries, with losses up to 2% of highly affected countries. And the reason they do that is that iron deficiency, as well as perhaps vitamin A deficiency, affects the child's intellectual development. If it affects their intellectual development, their ability to do well at school is impacted. Their ability to finish school is impacted, therefore they don't get as good jobs. So the health economists have suggested that with, for example, iron and zinc deficiency, because of the effect on school development, that it can affect up to 2% of the GDP of a country. And in fact, the Copenhagen Consensus, which is an organization of Nobel Prize economists, have suggested that it is the highest urgency priority in terms of value for dollars spent. So that's the big picture on vitamin and mineral deficiencies. So let me give you a case presentation. If I were a pediatrician, I would give you a case of a patient, but wearing my public health hat, I'm going to give you the case presentation of a country. And the country I've chosen as an example is Pakistan. Pakistan is a relatively large country with a population of around 162 million people. The literacy rate in Pakistan is around 46%. About 7% of the population are under 5 years of age, so we're talking about around 11 million children. The average income, or the GDP per capita, is around $2,000. The goiter rate from iodine deficiency, at least in 2005 or prior to 2005, was around 38%. Subclinical vitamin A deficiency rates were around 35%. And the rates of anemia in under 5 population at that time was estimated to be about 56%. And these are numbers taken from UNICEF and the Micronutrient Initiative in 2005. So let me first talk about goiter, and you all know what goiter looks like, but this is basically what goiter looks like. And if you think about goiter from iodine deficiency, you might suspect that one could say that we've actually have a successful approach to solving the problem of iodine deficiency, and that is the iodization or fortification of salt. Salt is a terrific vehicle to fortify, and it's terrific for a couple of reasons. Rich people use salt and poor people use salt. People who live in cities use salt. People who live in the countryside use salt. Therefore, it's a great vehicle to fortify. There are probably 150 countries in the world who have national legislation for the fortification of salt, specifically to solve the problem of iodine deficiency. So you would expect, with this very simple approach, that is adding a little bit of iodine to salt, that one would have a successful approach to iodine deficiency. And the reason I have successful in single quotations here is that it's not totally successful. This next slide is a little bit complicated, but it shows a summary of the situation in Africa, at least in 2008, in terms of the African iodine nutrition status. What I'd like you to notice is that at the top of the slide we have countries where one still has iodine deficiency, either severe, moderate, mild, or likely deficiency, and on the bottom are the countries where we have iodine sufficiency. And the red arrows here show that about 50% of the countries in Africa, despite having national nutrition legislation for the iodization of salt, about 52% of the countries still have iodine deficiency, with the estimate being that more than 300 million individuals still either have severe, moderate, mild, or likely deficiency. So despite the fact that this is a simple solution, nothing in public health is simple. And in fact, the solution to iodine deficiency, despite the concept being simple, is not indeed simple. The next vitamin we talk about is vitamin A. And here we have 3 successful approaches from a public health perspective. The first is to recommend that people diversify their diet to eat more dark and green leafy vegetables. And indeed, there have been many UN-led or not NGO-led programs to encourage people to have home gardening programs where they grow dark and green leafy vegetables, and people are encouraged to actually eat the vegetables rather than selling them. So the first public health approach is dietary diversification. The second approach is fortification. Once again, we fortify foods that are widely eaten in the population. And foods that are typically fortified with vitamin A include milk, which is widely used in most countries, sugar, which is widely used in many countries, oils, cooking oils are used in virtually every country in the world, and other foods. So the second approach for vitamin A is the fortification of foods commonly eaten. And for young children and women who won't eat enough dark and green leafy vegetables, who won't drink enough milk or sugar or take enough oils, we have supplementation with high-dose capsules. So one would think that with 3 reasonable public health approaches to solve the problem of vitamin A deficiency that I could stand up in here and say that it is not a relatively successful intervention, but it is absolutely successful. And unfortunately, that is not the case. You know that vitamin A deficiency affects the epithelial tissue of the body, including the epithelial tissue of the eye. Here we have beet host spots, and here we have blindness. In 2009, UNICEF estimated that around 33% or 190 million preschool children and 15% or 19 million pregnant women still do not get enough vitamin A in their daily diet and still can be classified as vitamin A deficient. So despite these relatively simple public health approaches, there is still a large number of people who suffer from vitamin A deficiency diseases. And although you might not be able to see the slide too well from the back of the room, if you can just look at the dark green, the countries that are marked with dark green, these are countries that have severe vitamin A deficiency. And what you can see from this slide, even from the back of the room, is that the word successful is not totally true when we're talking about vitamin A and public health. Having said that, I can tell you from a public health nutrition perspective, if you asked most nutritionists, they would say that our greatest success has been in our relative prevention of iodine deficiency diseases and vitamin A deficiency diseases. These would be quoted as successful programs. So, once again, we know what to do to improve nutrition and child survival, but we really don't know how to do it very well. And that's for vitamin A and iodine. The major challenge, because most people would say that if we're having problems with vitamin A and iodine, we're having even bigger problems with iron. In 1990, the World Summit for Children, which was attended by prime ministers, kings, and leaders of most countries from around the world, the 1990 World Summit for Children set a goal for the international health community to reduce iron deficiency anemia by 1/3 by the year 2000. It was not achieved. In 2004, the Millennium Development Goal set by the UN and the World Bank is to reduce anemia rates by 1/3 by the year 2015. So this is just a slide to show you that between the years 2000, which is the first blue arrow on your left, and the year 2000, which is the blue arrow on your right, not only was the international community unsuccessful in treating and preventing iron and iron deficiency and anemia, but indeed the numbers went up. And from this slide, you can see that if the population of the world was around 6 billion people in the year 2000, you can see that over 1 billion of the entire population of the globe has either iron deficiency or one of the iron deficiency disorders. So indeed, between 1990 and 2000, the entire global community was unsuccessful. If we look at particular regions of the world, and the region that I'd like you to concentrate on is India or South Asia, in 1990, the percentage of preschool children estimated to be iron deficient was incredibly at 80%. By 1995, the number had gone down to perhaps 76%, and you can see by the year 2000, the number was still well above 70%. India is a great example because India is doing incredible things in IT, incredible things with the economy, but in public health, I would argue that India remains where it was perhaps 50 or 60 years ago, and this is absolutely shameful. So, what are the risk factors for micronutrient deficiencies, including iron deficiency? And you will not be surprised by this slide. Here, the risk factors are diet. What you eat certainly does affect your intake of micronutrients. The age of individuals is very important. Children, during that important first 2 years of life, are certainly at huge risk, higher risk than any other time in their lifespan, because, of course, children double their birth weight by 4 to 6 months and triple their birth weight by 2 years of age. They also double and triple their need for micronutrients. There are seasonal effects on whether people can have micronutrients in their diet. Income, emergencies. If people live in arid rural areas, they may be affected. But the biggest factor affecting risk factors for micronutrient deficiencies is poverty. Where you find poverty, you find micronutrient deficiencies. In countries where there is less poverty, you find fewer micronutrient deficiencies. So this is by far the major factor affecting risk in children of micronutrient deficiencies. A question that one might ask is, what is the impact of iron deficiency and anemia on functional outcomes? That is, does it matter to children around the world? Should we be worried? And the answer clearly is yes. There are many children who die around the world from a severe anemia. And of course, the morbidity from moderate and mild anemia is quite well described. And the morbidity has to do with the effect of iron deficiency on both cognitive and motor development. I'm just going to show you one slide to illustrate the effects on cognitive development. This is a slide of a study where at age 5, children who had moderate iron deficiency anemia in the second year of life compared to a similar cohort still scored lower than children who had better iron status during the second year of life on tests of mental and motor functioning, even though the children at age 2 were perfectly treated for their iron deficiency. So what you can see on this slide is that tests of performance IQ, fine motor, gross motor, visual matching, quantitative concepts, picture vocabulary, and visual motor integration at school entry still were significantly lower in the children who had anemia at age 2, who had been adequately treated, but compared to the children who didn't have anemia, they score significantly lower on tests of motor and cognitive development. So I think it's fairly well established in the international community that the effects of iron deficiency are significant in terms of the actively growing child. So if we accept that, the next question would be, from a public health perspective, what are the choices for the treatment and prevention of iron deficiency? And I'd like to make the case that there are 5 choices. The first choice is an obvious one: increased variety of foods. As you well know, there are certain foods that have high amounts of bioavailable iron, and these foods are generally meat, poultry, and fish. But from a developing world concept, these are the most expensive foods, so that the public health approach to tell people to increase variety of foods, increase meat, poultry, and fish, is too expensive, and it simply does not work. The second choice is commercial targeted food fortification. In Canada, the major source of iron for children is formula, iron-fortified formula, and primarily iron-fortified cereals. So if we have breastfeeding children in Canada, in the first 2 years of life, the majority of the iron comes indeed from commercially fortified infant cereals. You can see that breast milk provides a little bit of iron, but not too much in the first 2 years. Meat provides some iron, but again, not too much. Fruit and vegetables, not too much. But the primary source of iron are in commercially fortified iron cereals in the developed world. But in the developing world, parents feed their children not with commercially available cereals, but foods that are locally available. So they make foods that are locally available. They don't buy commercially fortified cereals. Therefore, number 2 will not work in the developing world. The third choice is general food fortification. You may know that flour in many countries is fortified with iron. The problem is, for young infants, they simply don't eat enough of the fortified flour, and the level of fortification is targeted to the people who eat the most food. And you will not be surprised to know that adult males eat the most fortified food. Therefore, the level of fortification is targeted to the adult male, and it's simply too low to meet the needs of the young growing child. So general fortification will not work for the child under age 2. So in terms of public health choices, the first 3 of these do not work. We're then left with 2 things. One is individual supplements, and the second is the new one of home fortification. So what about individual oral supplements? Iron drops or iron syrup have virtually been around for probably 150 years. They are not a new intervention, and in fact, they're well used in many situations for the treatment of anemia. However, if we're talking from a public health perspective, where they have to be used for a long period of time, in the literature, there are no universally successful large-scale treatment programs, and in fact, no countrywide successful preventive programs for infants and children using drops or syrup. And the reason is a very practical one. It is because of issues directly related to compliance. So here are the compliance issues. First of all, the drops have a very strong metallic taste, and kids don't like taking them. You can force the child to take it for maybe a week or maybe 2 weeks or even a month. But if we're talking about months of intervention, it becomes very hard on the parent. The drops cause teeth staining, That is, they cause the teeth to be stained a dark brown color. You can get the staining off if you brush the teeth very hard, but of course most parents will not tolerate their children's white teeth turning brown. Many women in the developing world, especially the rural parts of the developing world, are illiterate, and it's very hard to measure the metric units in the drops of the syrup. There is a potential for overdose, and again, this medical model is very hard to sustain. So, liquid iron supplements simply do not work. There was no evidence that they work. I was asked by UNICEF, probably in the late 1960s, to help them with the problem they had. You may know that UNICEF has a catalog, and the catalog includes both food products, automobiles, computers, anything that's used in an emergency situation or a development situation. And the question that UNICEF had for its two consultants, and I was one of those consultants, was, should we include an iron product in our catalog? If we should, what should it be? And you must ensure that the advice you give us, UNICEF, is based on evidence. So the two consultants, myself and another person, went away, we read the literature, we came back to UNICEF and we said, there's probably 750 million in the children with iron deficiency anemia, you must take this on as a priority. And UNICEF said, we knew you were going to say that. The second thing they said is, of course, what should we put in our catalog? And it has to be based on evidence. So both consultants said the same thing independently. If it has to be based on evidence, we can't tell you anything to put into your catalog. And UNICEF came back and said, well, you can't tell me that there are 750 million children, but there's nothing we can do for them. We both said the same thing. If you want it to be based on evidence, we can't give you any suggestions. So they went back, they said to both of us, they said, well, really, try and come up with a solution that is going to start to solve this problem. So very quickly, our group in Toronto came up with a concept which we call home fortification. And this program includes, in theory, an alternate source of iron and an acceptable delivery system. So issues that were considered in the development of home fortification for infants and young children included all of the following. All infants ingest complementary foods. Therefore, complementary foods are a great vehicle for fortification. Once again, a complementary food is a perfect food because they go from breastfeeding to table food, but between those, every child, again, rich and poor, urban and rural, no matter where they live in the world, eat complementary foods. Therefore, it's a great vehicle for fortification. The form of iron is very important. It had to be a soluble form of iron that would be relatively well absorbed. The iron should not change the taste or color of the food into which it's added, and I'm going to address that in a moment. We must consider safety, that is, avoid giving too much but provide enough. And very importantly, because this is going to be used in a developing world context, it had to be inexpensive. One of the first questions I had is, if we're going to come up with a home fortification, the question would be, how much iron should we give to the infant in terms of home fortification? I apologize for this complicated slide, and I'm going to go over it quickly, but this is basically a slide showing the mean intake from complementary foods and breast milk compared to recommended nutrient intakes for an average child between 6 and 9 months of age. So on this vertical column, we have nutrient intakes for all of the nutrients you see on the left. In this column, we have the total intake from complementary food and the average intake from breast milk. So for example, for protein, you can see that the recommended amount is 9.1 milligrams. They get 2.7 milligrams from a typical complementary food. They get 6.7 from breast milk. So they get 103% of the recommended amount. So this is the total intake. And if we look at this slide, we can come up with at least 4 nutrients or micronutrients where the combination of complementary foods and breast milk does not come close to meeting the recommended nutrient intake. And those 4 micronutrients, not surprisingly, are vitamin A, where the combination provides 44% of the recommended intake. It contains vitamin D, where the combination is 12% of the recommended intake. Iron, where the combination is only 8% of the recommended intake, and zinc, where the combination is 40% of the recommended intake. So this is the general principle we used to come up with the amount of nutrients and those nutrients that should be used in a particular home fortification supplement. On the other hand, for example, protein provides 127% of the amount in terms of grams per kilo per day, copper 125%, and selenium 210%. So these would not be key micronutrients. So that was the concept that we used to come up with those nutrients that should go into home fortification. We decided that we could use a small sachet or packet. We could put the micronutrients in a powdered form, and in fact, we developed single-serve sachets containing a mixture of vitamins and minerals, easily sprinkled once daily onto many different types of food without changing the color, the taste, or the texture of the food. So again, here is the sachet. One doesn't have to be literate to use it. You open the sachet, and you actually can put it into any food that the parent is preparing for their young infant. Very importantly, we're not telling the parents to change the traditional food that they might have used in their locale, in their local community for 1,000 years. And finally, they mix it into the food, and that's it. It's benign to the child because they don't know they're getting it, and easy for a parent to use. The cost per sachet is around 1.5 US cents per sachet, and the cost per lifetime per child, at least for the product, not the delivery cost, but the product cost, would be about $2, which at least in our hospital is the cost of a cup of coffee. So, the advantages of this delivery concept, and this is what I said to UNICEF when it was simply a concept, was these are the issues that one must think about in order for it to be successful. It had to be easy to use and highly acceptable among families and children. It had to be a food-based rather than a medicinal approach for the reasons I've talked about. It would not require literacy to be successfully used. Very importantly, it does not conflict with breastfeeding practices. It is used on complementary foods, and of course, complementary foods should not be used prior to 6 months of age, so it doesn't conflict with breastfeeding practices. In fact, it can be used to promote the timely introduction of complementary foods at 6 months of age and proper weaning practices, because when one is doing public health information, one can say, introduce complementary foods at 6 months of age. In addition, give a package of micronutrient powders which will improve the quality of the food that you're providing to their infant. So we think it might be used to promote the timely introduction of complementary foods. They're lightweight, easy to store and transport, inexpensive, and low-tech to manufacture. So this is exactly what I said to the people at the UNICEF headquarters in Copenhagen. We came up with 2 formulations. One was what we call the nutritional anemia formulation, which contains iron, zinc, folic acid, vitamin A, and C. These iron doses were based on UN recommendations. And the other was what we called a multiple micronutrient formulation. It's very interesting that the cost of the 2 formulations is virtually identical. So if one is concerned about not getting all the micronutrients into a child because you're not sure what diet they're getting, for the same cost, you can provide 14 or 15 micronutrients compared to the 5 micronutrient formulation. Now, I mentioned that the iron doesn't change the taste, color, or texture of the food. And the way we get around that taste issue is by a process which is called microencapsulation. Encapsulation is a process used in the pharmaceutical industry to mask the taste of a very strong-tasting pharmaceutical. And in fact, it's widely used in the pharmaceutical industry. And in fact, many of the common over-the-counter drugs that we would normally take are all microencapsulated to mask the taste. So the idea that we came up with is that we could microencapsulate molecules of iron or taste mask them. The encapsulate would be a lipid-based encapsulate which would dissolve in the low pH of the stomach. And by using the microencapsulated iron, we could prevent changes in the taste of the food into which it's added, prevent changes to the color of the food, and it would have no effect on the texture of the food. Again, we presented this as an idea to UNICEF. And here's what UNICEF said back to us. They said, "This sounds like a great idea. Here are the 5 things you have to do to get us, that is the UN, to take this on as our initiative. Here are the 5 challenges." They said, first of all, you have to show that it works. You have to prove efficacy because you're using a microencapsulation that's never been done before. You're adding the iron to food, and we know that when you add iron to food, it decreases the bioavailability. So you have to prove that it will be well absorbed and used by the infants. You have to show that people will use it. It's not well enough to show that something works if it's too expensive. So you have to prove efficacy and prove effectiveness or acceptability. You have to have someone make it in large volume at a low cost. They said, Dr. Zlotkin, you said there were 750 million children in the world. If each child has to get, let's say, 100 of these sachets, If you multiply 100 by 750 million, you get a very large number. So they said you have to get someone to make it large volume, low cost. Then you have to come up with some successful models of implementation and demonstrate that it can be scaled up in at least one country. So loving a challenge, for the next 10 years of my life, I took on these 5 challenges, and I'm going to give you the next 10 years of my life in the next 10 minutes. So the first of the challenge was to show that it worked. So by using stable isotopes with funding from the Canadian Institutes of Health Research, we were able to do absorption studies, and I'm not going to go into the detail of the studies, but suffice it to say that with our partners in Ghana, we took infants who had iron deficiency anemia, we had infants who had iron deficiency without anemia, and we had otherwise healthy infants. We gave them the microencapsulated iron, but in this case, the iron was a stable, non-radioactive isotope of iron. What we demonstrated that in the group with iron deficiency anemia, their iron absorption was 8.3%, which for you non-iron experts is pretty good. For those with iron deficiency or iron sufficiency, they still absorbed 4.5 or 4.7% of the iron. So this is an important study to demonstrate that even when you microencapsulated iron and add it to food, the absorption is not unreasonable. It's pretty good. So it was well absorbed. The next study we asked ourselves would be, what is the most effective but lowest dose we could put into the formulation? Because, of course, we wanted to be inexpensive, so we wanted to find the lowest dose. So this is a randomized controlled trial where we provided 3 different doses of microencapsulated iron in a sachet with other micronutrients in the powder form. So infants at the beginning of this study, in the A here, all had anemia with hemoglobins less than 90. We provided 12.5, 20, or 30 milligrams of iron, and as you can see here, all groups of infants had a fairly robust response after a short 2-month period. So our conclusion from this was that we could use 12.5 milligrams of iron, which happened to be the WHO recommended dose of iron at that time, in the individual sachets. When we did our studies, and we did multiple studies in countries around the world, we always did focus groups with the women, mothers in the study. We said, did you like using the sprinkles? Did you have any trouble? Did the children object to it? Was it difficult to use the sachets? And most of the mothers who were the participants would say it was easy to use, the kids didn't know they get it. The only problem they had was that it was hard to use on a daily basis. For example, in Bangladesh, in the small villages, they said that we would have to go out to the field or go to the market every Tuesday. We missed every Tuesday. In other countries, they would say we had other things to do. We would miss 1 or 2 days. And in fact, if we missed 3 days, we thought we had blown it, and we simply gave up. So we designed a study to ask what is the best way to provide something that is not a medicine, but is a public health intervention. And here's the study. We call this our flexible administration of sprinkles. So we randomized children with anemia into 3 groups. The first group got 1 sachet per day for 30 days, and that's the daily 2-month group. In the second group, we gave them 60 sachets over a 3-month period, and the advice we gave to the mothers was that if you miss a day or 2, it doesn't matter. Simply use up all 60 sachets. And in the third group, we provided the same 60 sachets, but this time over 4 months, and again, we saved the same advice. If you miss a day, it doesn't matter. If you miss 2 days or even 4 days, it doesn't matter. Simply finish all the sachets over the 4-month period. And this is the result of the study. What you can see here is that the percentage of children with anemia at the beginning of the study was 100%. Was 75%, 82%, and 72%. At the end of the 2-month intervention, 45% of the children were anemia in the 2-month group, 40% in the flexible group, and the group that had the best response was the group that had the most flexibility. At the end of the 4-month group, where they all got 60 sachets, the rate of anemia had gone down from 72 to 30%. You may say to yourself, well, still 30% of the population is pretty big. But remember, the Millennium Development Goal for 2015 is a 1/3 reduction in the rates of anemia in the country. And this is certainly greater than a 1/3 reduction. We followed the same group of infants for an additional 6 months with no intervention. And once again, you can see that the group that got the flexible 4-month group, the group that got 60 sachets in the flexible group, had in fact the most favorable response. This next slide shows the mean adherence to the 60 sachets. In the daily 2-month group, 88% of the 60 sachets were used. In the middle group, 93%. And in the final group, virtually all the sachets were used. So what this told us is that from a public health perspective, we should use a model that allows the most flexibility. Not only is it easier for the caregiver to give it, but indeed we have the most promising response. So going back to the challenges, one, we did a number of studies in countries around the world to show efficacy. Two, we did a number of studies to show acceptability. The third one was large volume, low-cost production. When we started our research studies, we had no source of supply. So the source of supply was indeed in the hospital kitchen. This is a picture of me in our hospital kitchen. I work in a large hospital, and we have a very modern kitchen. And today in our kitchen, we bring things in cold and we heat them up, or we bring things in hot and we cool them down. In fact, we don't make much in our hospital kitchen, but it's been there for probably 60 or 70 years. We have all this great equipment in our kitchen. The chef in our kitchen was a guy named Marcel, and I swear this is a true story. For a bottle of scotch each month, he would let us into the kitchen at night, and he would let us mix our concoction of powdered micronutrients together. So for the first research studies, we actually mixed the micronutrients on our own, sent them to a local manufacturer to put into the small sachets, and we were able to do studies in 10 different countries using this mom-and-pop methodology. With the success of the program, we realized that we could not make all the sachets we needed in the hospital kitchen. Therefore, we were able to actually transfer the technology for making the sachets, and we were able to build capacity to package sprinkles close to where they were used. And this is actually the machine that puts the powder into a little sachet. The powder goes into the top. You can't see it very well, but here are the packaging material, and the packages drop out the bottom end. I say it's relatively simple. It's not perfectly simple, but it's not particularly sophisticated. So we actually, during the research studies, we established public-private partnerships with production facilities in India. We had one in Canada, in Guyana, in Indonesia, in India, and Pakistan, and these were very close to where the actual product was being used. These were the rinky-dink first production facilities. With time, we actually realized that this was going to be successful, and now these are produced in a number of sites using a fairly sophisticated, much more sophisticated machine, which you can see on the right side there. These are the rolls of the paper or polyethylene that's used in the packaging. Here you see people with the individual sachets checking them out, and here you see putting the sachets in the box. So just to give you an idea, once again, about the acceptability, and here, starting the modeling of knowledge translation and implementation, one of the first countries where we did a non-research study, but a distribution study, was Mongolia. And this slide is really important because it demonstrates a number of important points about distribution and scaling. The first point is you can see that the sachet was written in Mongolian script. And for those who read Mongolian script, you can see that the formulation contained iron, vitamin A, but it also contained vitamin D, because in Mongolia, they have two major nutritional problems. They have iron deficiency anemia, but they also have vitamin D deficiency rickets. Actually, the children in Mongolia drink a lot of milk, but it's actually direct from the animal. It's not centrally supplied, so there's no opportunity to fortify the milk. So the two major micronutrient deficiencies are iron and vitamin D. And this is a picture of a child holding a sachet of the Mongolian sprinkles in what is probably the most challenging country in the world to do a distribution study, because most of the population lives in yurts or gers like this. I took this picture, and it's really tough to do distribution. So in this first distribution study, we included around 13,000 infants who were identified for participation in this distribution program. The coverage, that is, we reached about 84% of eligible children. In this case, we defined eligible children as all children between age of 6 months and 5 years. And 74% of those children had their monthly supply delivered to them and consumed the supply. The cost of the sprinkles delivered to Ulaanbaatar was about 3 cents per sachet. And most importantly, at the end of this 2-year intervention, we demonstrated from baseline to 2 years later a significant decline in the rates of both anemia and rickets. So the implications from this very important study were, and by the way, we worked with an NGO, we worked with World Vision and the government of Mongolia for this implementation trial. So the implications are that NGO distribution of sprinkles may be effective in reducing the prevalence of both deficiencies. And in fact, due to the primary success of this program, we expanded to 2 other pilot areas, and now it is part of national legislation. And in fact, scaling up is actually, Mongolia is the first country where there's national scale up of this particular intervention. So the final challenge is developing a sustainable distribution and supply system at scale. This is by far the most difficult, especially for an academic from a developed country. Sustainable distribution programs or scaling must be able to reach and provide micronutrient powders like sprinkles to the most vulnerable populations. The goal is scaling to the national level. So, you've seen this slide before, but I'm going to show it to you again. You remember the left-hand side of the slide, we have research projects. You take these projects and you apply some type of meta-analysis until you get a proven intervention. You use the techniques of knowledge translation to develop some local projects. You need a champion or a sponsor, and using implementation science to expand the local projects to subnational coverage. And then you can take it to scale by either expanding the local projects or some type of franchising until you have national coverage. So that, again, is the general. So here's what happens with micronutrient powders. We actually did research projects in 14 or 15 different countries. I was naive enough at the beginning to think if we did 1 or 2 great randomized controlled trials that were published in good peer-reviewed journals that everyone would say, that's absolutely adequate. That wasn't true. When I went to Nigeria and I said, look, we've done a great study in Ghana, they said, well, of course, the children in Ghana are quite different from the children in Nigeria. When I went to Ghana, and I went to Cote d'Ivoire, which is the country that borders Ghana, and I said the same thing to the Ministry of Health. We've just done a study in Ghana, and they said, well, our children in Cote d'Ivoire are totally different. So we actually had to do multiple studies, not in every country in the world, but multiple studies. There was recently a Cochrane systematic review which proved the efficacy of micronutrient powders. Using knowledge translation, we developed local projects in Mongolia, in Nicaragua, in Pakistan, and then using some of the techniques of implementation science, we expanded these programs under the partnerships of the public sector, that is the governments in these countries, the United Nations, including UNICEF, the World Food Program, and various types of non-governmental organizations. We needed a champion to do that, and we had a number of champions, but the most important champion was UNICEF, World Vision, and a number of the NGOs. There is subnational coverage for micronutrient powders now in 20 countries, and it is being taken to scale through either expansion or a franchise model in at least 5 or 6 countries, with many more on the way. The important component here is that UNICEF is currently the champion of this intervention. So here's the big picture. We started off 12 or 13 years ago with this big picture. And the big picture was that first we had to do efficacy studies, including bioavailability, and we did these studies in Ghana, and Canada, and India, China, Pakistan, Vietnam, Bolivia, Bangladesh, Indonesia, and more. We developed the product in the hospital kitchen, but once the efficacy studies were successful, we went on to some effectiveness trials to show that it was actually working. We advocated for nutrition policy in countries like Mongolia, Bolivia, Indonesia, and China. We did consumer research. We developed the product. We found cost-effective manufacturing. We developed distribution strategies and some pilot implementations and scaling. And now, as I said, there's distribution by governments, NGOs, and UN agencies in a number of countries around the world. So the final proof of success, if I can call that proof, is that about a month ago, in 2011, the World Health Organization put out some guidelines, or actually had guidelines, but amended the guidelines to recommend home fortification of foods with iron-containing micronutrient powders to improve iron status and reduce anemia among infants and children 6 to 23 months of age. The fact that the WHO has taken this on as a recommendation means that it likely will go to many of the 160 countries in the UN family. So once again, I'm going to show you this slide that I showed you about 35 minutes ago. So these are the characteristics of an intervention that facilitates the successful scaling. First of all, credibility. It has to be based on sound science. And I would argue that the multiple studies that we did in countries around the world prove that it is strong science. Observable to ensure that potential users can see the results. I didn't tell you, but in many situations around the world, and you will know this, when you take a child with iron deficiency anemia and you provided them with iron, the child changes. They go from being inactive to being relatively active. And parents can notice this. It's an observable change. Many parents came to me and said, by giving my child sprinkles, they become naughty. When they said naughty, they said this with a sprinkle in their eye. They actually meant that the child had improved in terms of their behavior. Relevant for addressing persistent problems, there's no question that iron deficiency is a persistent, huge standing problem. Has a relative advantage over existing practices. I mentioned to you that the oral iron drops and iron syrups has been unsuccessful. Therefore, it does have a relative advantage over existing practices. Easy to use and understand. I think I've made that point. Demand is already present or can be created. This is something we're continuing to work on. It is not clear to most parents that their children might have iron deficiency or micronutrient deficiencies. There is a demand by those who are distributing the product. There is a need for those distributing the product to actually create the demand. And finally, it is indeed compatible with potential users' established values, norms, and facilities. I've had the phenomenal privilege of perhaps working in 40 or 50 different countries over the last 14 or 15 years. And wherever I go, and whichever parents I talk to, they all say the same thing to me. When I say to them, what do you want for your child? They say, I want my child to have an education. I want them to be healthy. I want them to have a good job. I want them to have a roof over their head. I want them to get married and have a healthy, happy life. Every parent from every country I've ever been says this. This is very compatible with the small influence of micronutrient powders, what I've been talking about. So, just to remind you that although primarily I've been talking about measurement of iron, in our micronutrient powders we also contain vitamin A to prevent blindness, and indeed Ghana, vitamin A deficiency is still a major problem. In Mongolia, I've also mentioned that iron and vitamin D deficiency are both major public health problems, and you can see from the slide that our sachet contains both iron and vitamin D. In Bangladesh, where 80% of the children are anemic from iron deficiency, with some degree of arrested development, of course, sprinkles contains iron to prevent anemia. And finally, back to Pakistan, not only do the sachets in Pakistan contain iron and vitamin A, but they also contain zinc, which is shown to reduce morbidity from diarrhea, pneumonia, and other infections. And in fact, in Pakistan, they have a fabulous distribution program through a public sector program called the Lady Health Worker Program, and I also use subsidized private sector distribution. The Lady Health Worker Program consists of 100,000 lady health workers in rural Bangladesh with the potential to reach 7 million children. So finally, the impact to date of our program through the Sprinkles Global Health Initiative, we've reached at least 10 million children in 41 countries. There are well more than 6 manufacturing facilities. The production in 2010 was more than 300 million sachets. The distribution models we came up with were public sector models, that is government, UN sector, and non-governmental organizations. We've been successful in our advocacy program so that in 7 countries, micronutrient powders are part of the national nutrition policy, and the impact where it's being used is as high as 40 to 50% reduction in the prevalence of vitamin and mineral deficiencies, where once again I'm going to remind you that the Millennium Development Goal is a reduction 1/3 by the year 2015. Where are we going as an organization? Our mission remains to prevent malnutrition-related deaths, to support the right of children to meet their full potential for growth and development, and our goal is to work with our partners to scale up from 10 to 50 million children over the next 5 to 10 years. Of course, I can stand up here and tell you about sprinkles, but the program has involved many individuals in Toronto and around the world, students and various workers, and I thank all of the people listed on this slide. And of course, the multiple studies, the multiple implementation programs involved many of the collaborators, or all the collaborators shown in this slide, and many, many more. And I'm going to end up with this final slide, which says that ending vitamin and mineral deficiencies worldwide is in fact the goal. And a comment from the World Bank is that probably no other technology available today offers as large an opportunity to improve and accelerate development at such low a cost in such a short time. Thank you for staying to the bitter end. Greatly appreciated.
Thank you very much, Professor Zlotkin, for fantastic, a wonderful talk, but also your enthusiasm and how you started the high standards you set, the high challenges, how you've achieved them. But I would like to stay with the principles of your talk and your approach at the beginning and at the end as you summarize them, because I think it's a fitting conclusion and a great reflection the last 3 great days we've had here at the conference, because you set these huge issues in a public health context. You looked at the global implications, translation, implementation of evidence, and I think across of that, it was the overarching holistic approach, as you said, towards the end to child well-being. So thank you very much for that.
A great pleasure.
Thank you.